Good morning, everyone. My name is Lemia Saykhan, and today my colleagues and I we're going to present our CPC case for CPC 622, which is directed by Dr. Crystal Lee. Starting off with the patient data, he's a 13 years old male patient. According to the past medical history that was given, the patient is suffering from bronchial asthma, and will be managed through corticosteroid inhalers. The patient came complaining from painless swelling in the upper lip region of the face. Upon clinical examination, expansal swelling noted on the attached mucosa, preapical to the 1121 region. Palatal cortical plate expansion is noted. No tenderness on palpation. Swelling is a hard inconsistency. Pulp vitality tests show that all teeth from 1-3 to 2-3 are vital.
Hello everyone, my name is Rawan Al-Garni and I'm gonna continue the radiograph. CT scan demonstrates circumscribed lesion in the midline of maxilla with no destruction of cortical boundaries. Sagittal section, the lesion is in preapical region of tooth number 11, tooth number 21 without contacting the root of the teeth. Radiographic interpretation, set and location in the midline of maxilla between tooth number 11, tooth number 21. Size and shape round ovoid approximately 1.5 cm. Internal structure, well circumscribed radiolucency. Effect on surrounding structure, no effect in contact the root of the teeth. Outline, sclerotic border. Differential diagnosis, nasopalatal duct cyst, central giant cell, simple bone cyst, gibrism.
Hello, my name is Elmaha Sultan and I will represent our differential diagnosis, starting with nasopalatine duct cyst. The nasopalatine duct cyst may develop at almost any age, but is most common in the 4th to 6th decade of life. It is common in men. Usually it is asymptomatic. They present as a swelling of anterior hard palate. They must usually be larger than 0.6 centimeters to distinguish cyst from incisive foramen. Radiographic features, it is a solitary, well-defined oval or round unilocular radiolucency between central incisors. It is larger than 0.6 centimeters in diameter. They may appear as a heart shape if the anterior nasal spine is superimposed. Root resorption and tooth displacement may be present. Etiology, it is a developmental non-odontogenic cyst. The lesion most likely represents a spontaneous cystic degeneration of remnants of the nasopalatine duct. Management, inoculation is usually curative and reoccurrence is rare. Histological confirmation is recommended. Second of all, central giant cell. Clinical features, it occurs exclusively on the gingiva or edentulous alveolar ridge, presenting as a red or red-blue nodular mass. Most lesions are smaller than 2 centimeters in diameter. The lesion can be sessile or pedunculated and may or may not be ulcerated. Peripheral giant cell granuloma often is more blue-purple, can develop at almost any age. It may develop in either the anterior or posterior region of the gingiva or alveolar mucosa. Radiographic feature, a small lucent region, and gradually as it enlarges, thin tubercles of bone become apparent, giving it a honeycomb multilocular appearance. The lesion may demonstrate expansion, root resorption, and erosion through or remodeling of the overlying cortex. Etiology, trauma can be an important factor to the initiation of central giant cell. Endo, hemorrhage response to previous traumatic or inflammatory episodes. Management, usually treated by curettage. Studies indicate a recurrence rate of about 15 to 20%. Long-term prognosis is good and no metastasis reported. Thank you.
Hello, my name is Yara Al-Kinani. I'll be continuing differential diagnosis. Simple bone cyst, clinical features, 10 to 20 years old, common in men, usually seen in the posterior mandible, slowly enlarging swelling and teeth affected are vital. Radiographic features, radiolucent lesion in the posterior region of the mandible, rounded or oval and solitary. The outline is irregular or scalloped and the border is usually ill-defined. Etiology is unknown and the management careful curettage of the lining. Chirurgism. Clinical features, common to be seen in children, maxillary and mandibular involvement, symmetric and asymmetric, often results in displacement of teeth and distortion of the nasal cavity. Radiographic features are bilateral multinucleated, mixed radiolucent and radioopaque pattern. Grounded glass, orange peel, pebbled appearance of bone. The etiology, autosomal dominance disorder, and the management, endocrine disturbance may be treated, is a self-limited condition and regress with age, and surgery is indicated only in aggressive cases. Thank you.
Good morning, everyone. My name is Rima. This is our case analysis according to the age, gender, site, periphery and shape, internal structures, and its effectiveness on the adjacent structures. Our definitive diagnosis is nasopalatine duct cyst, which has another name, which is the incisive canal cyst. The lesion affects the maxilla more than the mandible. The most common site is the upper incisors region. Most studies have shown a male predilection. The most common symptom is swelling of the anterior palate. Many lesions are asymptomatic and discovered on routine radiographs. Well circumscribed radiolucency in or near the midline of the anterior maxilla, between and apical to the central incisors. Fine needle aspiration cytology, the cyst wall increased and white cloudy fluid was drained. The treatment of nasopalatine duct cyst is by inculation via a palatine or buccal approach. A surgical inculation and biopsy will be done. Transnasal endoscopic marsupialization can also be applied.
These are our references. And thank you for your listening.